Good afternoon. First, I'd like to thank Beth Oliver and Antoinette for arranging this symposium. And today we'll be talking about diabetic management to reduce cardiovascular events. I have no conflicts of interest, nothing to disclose. So diabetes refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. Several distinct types of diabetes are caused by a complex interaction of genetics and environmental factors, including decreased insulin secretion, decreased glucose utilization, and increase in glucose production. 29.1 million Americans have diabetes. 21 million were diagnosed, and 8.1 million were undiagnosed. 1.4 million Americans are diagnosed with diabetes every year. Diabetes remains the 7th leading cause of death in the United States. Over 69,000 death certificates listed diabetes as the underlying cause of death. Some risk factors for diabetes include an A1C of greater than or equal to 5.7, first-degree relatives with diabetes, high-risk race, ethnicity, women who were diagnosed with gestational diabetes, a history of cardiovascular disease, hypertension, hyperlipidemia, and physical inactivity, just to name a few. So hemoglobin A1C testing should be performed routinely on all patients with diabetes at initial assessment and as part of continuing care. Measurements every 3 months determines whether patients' glycemic targets have been reached and maintained. For patients meeting treatment goals and with stable control, it's feasible to check the A1C twice a year. And for those whose therapy has changed or who are not meeting their glycemic goals, quarterly is reasonable as well. So this chart, this slide shows the correlation between A1C levels and the mean glucose levels. So if we look on this side over here, you can see the A1C and the mean glucose plasma, the fasting, the pre-meal, post-meal, and bedtime. So for example, if we look at an A1C of 11%, you can see that the mean plasma is 269, which is pretty high. So for the medical treatment of type 2 diabetes, metformin has a long-standing evidence base for efficacy and safety. It's inexpensive and may reduce the risk of cardiovascular disease. Consider insulin therapy with or without additional agents in patients with newly diagnosed type 2 diabetes who are markedly symptomatic and or have elevated blood glucose levels of greater than or equal to 300 or an A1C of greater than or equal to 10%. So long-term use of metformin has been associated with vitamin B12 deficiency. And periodic measurements of vitamin B12 levels should be considered in metformin-treated patients, especially those with anemia or peripheral neuropathy. So this slide is based upon the American Diabetic Association. It's an overview of the treatment algorithms for type 2 diabetes. Moving from monotherapy, which you would start with, and as time goes by and as warranted, you would increase to dual therapy, triple therapy, and then finally combination injection therapy. And these are the type of medications you would use for each category. Some complications and comorbid conditions that occur with diabetes include hypoglycemia, hypertension, hyperlipidemia, cardiovascular death, and heart attack. Cardiovascular disease accounts for most morbidity and mortality in patients with diabetes. It's the leading cause of morbidity and mortality. And diabetic patients are known to have 2 to 4 times increased coronary artery disease risk, and CAD has been reported to occur 2 to 3 decades earlier in diabetic patients. Diabetes causes microvascular complications such as nephropathy, neuropathy, and retinopathy, as well as macrovascular complications, which are primarily diseases of the coronary arteries, peripheral arteries, and cerebral vasculature. It's associated for an increased risk of MI across the spectrum of acute coronary syndromes, and patients with diabetes have worse cardiovascular outcomes after ACS events. So this slide is also from the Triton-TIMI 38 randomized trial that Dr. Kinney mentioned, but it also looked at patients without diabetes and those with for an incidence of cardiovascular disease, MI, and stroke. And as you can see, there's a huge difference between patients that did not have diabetes and those that did. For bleeding, they were pretty much the same, and again, another huge increase difference for cardiovascular disease, MI, death, CVA, and bleeding. Okay, numerous studies have shown the efficacy of controlling individual cardiovascular blood pressures in preventing, in preventing and slowing of cardiovascular disease in people with diabetes. The American Diabetic Association recommends systematic assessment, at least annually, of all people with diabetes for cardiovascular risk factors, including hyperlipidemia, hypertension, smoking, family history of premature coronary disease, and the presence of albuminuria. Abnormal risk factors should be treated. Okay, hypertension is common diabetic comorbidity that affects many patients, with the prevalence depending on the type of diabetes, the age, the BMI, and ethnicity. Hypertension is also a major risk factor for both cardiovascular disease and microvascular complications. So some recommendations for hypertension and blood pressure control include people with diabetes and hypertension should be treated to a blood pressure goal of less than 140/90, and lower blood pressure targets such as 130/80, less than, may be appropriate for certain individuals with a high risk of cardiovascular disease. This new recommendation for 2017, according to the ADA, says that for people with higher blood pressures, treatment should be initiated with 2 blood pressure lowering agents given as 2 pills or a single pill with a combination instead of a single medication. This DASH, the Dietary Approaches to Stop Hypertension diet style, which encourages a reduction in sodium and an increase in a variety of foods that help lower blood pressure. And also moderation of alcohol and increased physical activity. Here is showing you an idea of the DASH diet that's recommended. It shows you all of the different servings for the different types of food. And as you can see, all the good stuff like ice cream, sugar, and candy, you're only supposed to have less than 5 servings of sweets per week. Okay, so pharmacological therapy for patients with diabetes and hypertension should include drug classes that demonstrate to reduce CV events in patients with diabetes, as shown here. Multiple drug therapy, 2 or more agents at maximum doses, are usually required to achieve blood pressure targets. Lipid abnormalities are common in patients with diabetes and undoubtedly contribute to the increased risk of cardiovascular disease. In adults not taking statins, there are several patients where it's reasonable to obtain lipid profile. A screening lipid profile is reasonable at the beginning of diagnosis, at the initial medical evaluation, and every 5 years or more frequently as indicated. Lifestyle management should focus on weight loss if indicated, reduction of saturated fats, trans fats, cholesterol, an increase in omega-3 fatty acids, viscous fibers, and plant sterols, and an increase in physical activity. For patients with triglyceride levels greater than or equal to 150 or low HDL, intensify lifestyle modifications and work to optimize glycemic control. If triglycerides are 500 or higher, we must evaluate for secondary causes and consider medical therapy to reduce the risk of pancreatitis. So this slide here is a summary of the recommendations for statin treatment in people with diabetes. All of these recommendations are in addition to lifestyle therapy. So for patients that are less than 40 years old and they have no risk factors, you would not start them on a statin therapy. If they did have some cardiovascular risk factors, you would start them on a moderate or high dose. And the same for patients that are greater than 75. If they have ACS and LDL greater than or equal to 50, you would start them on moderate therapy in addition to Zetia. Okay, so combination therapy, statins, fibrate, has not been shown to improve cardiovascular disease outcomes and is generally not recommended. However, therapy with statin and fenofibrate may be considered for men with both triglycerides greater than or equal to 204 and in HDL less than or equal to 34. Combination therapy of statin and niacin has not been shown to provide additional cardiovascular benefit above statin therapy alone and may increase the risk of stroke and is not generally recommended. This slide shows an example of statin therapies. So for dosing for high and moderate intensity therapies, and note that these doses are all based on once daily dosing. My colleague Gloria Manzanilla will be going over lipid management in her talk after me, so I'm not going to go into too much detail. But as you can see here, high intensity statin therapy will lower the LDL by about equal to 50%, and the moderate intensity statins will lower by 30 to 50%. Okay, so aspirin, when discussing primary prevention, the benefits of daily aspirin for primary prevention of cardiovascular disease in patients with diabetes and cardiovascular disease risk factors, but without known cardiovascular disease, is uncertain. In a meta-analysis of 10 trials evaluating aspirin for primary prevention, aspirin moderately but significantly reduced the risk of major CV events compared with a placebo or no treatment. With secondary prevention, the merits of daily aspirin in patients with existing cardiovascular disease are widely accepted. A meta-analysis of randomized trials of antiplatelet therapy for the secondary prevention of cardiovascular disease in high-risk patients showed that aspirin produced statistically significant and clinically important reductions in the risk of subsequent MI, stroke, and vascular death. Consider aspirin therapy for patients with diabetes who had an increased risk of cardiovascular risk. This includes most men and women with diabetes, aged 50 years and up, who have at least one additional major risk factor and are not at increased risk of bleeding. Aspirin is not recommended for those with low risk of cardiovascular disease, such as men and women with diabetes under the age of 50 and with no other major cardiovascular risk factors, a 10-year cardiovascular risk under 5%, as the benefit is likely to be outweighed by the risk of significant bleeding. The screening of asymptomatic patients with high cardiovascular disease risk is not recommended in part because those high-risk patients should already be receiving intense medical therapy, but do consider investigations for coronary artery disease in the presence of any of the following: atypical cardiac symptoms like unexplained dyspnea, chest discomfort, signs or symptoms of associated vascular disease including carotid bruits, TIA, CVA, PAD, and EKG abnormalities. Patients at an increased risk of cardiovascular disease should receive aspirin and a statin and an ACE inhibitor or ARB therapy if the patient has hypertension, unless there is a contraindication to a particular drug class. So the next, we're going to move on to non-pharmacological therapies, because when you're talking about decreasing cardiovascular risk, it's not just pharmacological therapy, it's also lifestyle changes, which include exercise, diet, watching the blood pressure, and stopping smoking cessation. So in accordance with the National Standards for Diabetes Self-Management, Education, and Support, the association recommends that people with diabetes should participate in a diabetes self-management education to facilitate knowledge, skill, and ability necessary for diabetes self-care, and for diabetes self-management support to assist in implementing and sustaining skills and behaviors needed for ongoing self-management, both at diagnosis and as needed thereafter. Figuring out what to eat can be the most challenging part of daily self-management for people with diabetes. The ADA has long held that there is no one-size-fits-all approach to nutrition therapy and lays out 4 goals to nutrition therapy. 1 is to promote and support healthful eating patterns, emphasizing a variety of nutrient-dense foods and appropriate portion sizes to improve health and to achieve and maintain body weight goals, attain individualized glycemic, blood pressure, and lipid goals, delay or prevent complications of diabetes. To address nutrition needs based on personal and cultural preferences, health literacy, access to healthful foods, willingness and ability to make behavioral changes and barriers to change. 3rd, to help patients maintain the pleasure of eating by providing non-judgmental messages about food. And finally, provide the individual with diabetes the tools for developing healthful eating patterns rather than focusing on individual macronutrients, micronutrients, or single foods. This is also a chart showing the diet that's recommended for patients with diabetes. It shows good eating habits, foods to avoid, when to eat, and it also breaks down the individual food groups and what's acceptable to help lower diabetes. The glycemic index is a particular type of food that indicates the food's effect on a person's blood glucose. A low GI is 55 or below, medium GI is 56 to 69, and a high GI is 70 or higher. Foods with a low glycemic index are more slowly digested, metabolized, and cause a slower rise of blood glucose. Conversely, foods with a high glycemic index values are those which are rapidly digested, metabolized, and result in marked fluctuations in blood glucose levels. Adults with diabetes who drink alcohol should do so in moderation, which is defined as no more than 1 drink per day for women and no more than 2 drinks per day for men. Because alcohol consumption may place patients with diabetes at an increased risk for delayed hypoglycemia, it's important that they are able to recognize and treat the signs and symptoms of hypoglycemia. Most adults with diabetes should exercise at least 150 or more minutes per week of moderate to vigorous activity over at least 3 days per week, with no more than 2 consecutive days without exercise. Resistance training may also be performed in 2 to 3 sessions per week. It is important to advise patients with diabetes to not use cigarettes, other tobacco products, or e-cigarettes. Now, with e-cigarettes are hard because there just are no rigorous studies demonstrating that the e-cigarettes are healthier alternatives to smoking, or that e-cigarettes can facilitate smoking cessation. Therefore, it's advised to recommend against their use. Emotional well-being is an important part of diabetes care and management. Psychological and social problems can impair the individual's ability to carry out diabetes care tasks and therefore compromise their health status. Psychological care should be provided to all patients with diabetes with the goal of optimizing health outcomes and quality of life. So in summary, men and women with diabetes are at increased risk for developing and dying from cardiovascular disease compared with non-diabetics. Those with diabetes have a decreased life expectancy. At the time of diagnosis, many patients already have 1 or more risk factors for macrovascular disease: obesity, hypertension, hypolipidemia, and smoking. And many have overt atherosclerosis. Prevention of cardiovascular morbidity is a major priority for patients with diabetes. Studies have suggested that a substantial reduction in cardiovascular mortality in patients with diabetes should be achieved by smoking cessation and aggressive treatment of hypertension and hypolipidemia. It's important to remember that the benefit of multifactorial risk factor reduction strategies are necessary to successfully diminish the risk of cardiovascular events on patients with diabetes. Thank you very much.